The UK is not alone in extending powers to prescribe beyond doctors to nurses, pharmacists, and allied health professionals. Other countries like New Zealand, Ireland have something similar, but now the UK has the most extended prescribing rights for nurses in the world, and they were often at the forefront of, for instance, introducing those prescribing powers to allied health professionals. When we were looking, HSR UK is the national network for health service researchers. When we were looking with Kaleidoscope at the kind of case studies that we might pick to look at successful system changes, we had three criteria. So there was topics with demonstrable positive impact. There had to be some sort of grounding in research, where research had played a part in either sort of making the case for the change or evaluating its impact. And that there was some wider learning beyond the topic itself, which might be important for the health service. So the story, we're going to hear more from our speakers about how it happened, how it's been sustained. And I think it's a story not of overnight change, but sort of a gradual incremental shift. And I know Christine in particular is going to talk about some of the kind of policy and practice run up to that. But what prompted it, I think, was partly the demands on doctors, the recognition that there were some issues, particularly thinking about prescribing errors by junior doctors. So it's quite well known, it's quite an established medication safety literature showing prescribing error rates of between 2 to even 500 per thousand items prescribed by junior doctors, but also the kind of growing complexity of patients with a lot of comorbidities, meaning fragmented care, having to wait for sometimes quite kind of basic medication, so delays in access, particularly for people with very complex health needs or in areas like end-of-life care, where not being able to access essential medications, particularly out of hours, is a real problem. So what we've seen since that point, since 2006, when independent prescribing was enshrined in law, has been a number of schemes from ward-based pharmacists in hospital to nurse-led clinics for diabetes or renal failure, through to allied health professionals, to physiotherapists or paramedics, having powers to prescribe as part of a kind of clinical management of the patient. And a Cochrane review 4 years ago by Week showed equivalent or better quality in terms of prescribing errors and other kind of safety assessments, and that non-medical prescribing is very acceptable to patients. Evidence being quite a kind of incomplete evidence base at the minute, with some risk of bias, but there's still a kind of growing picture of a very acceptable and positive change. There's some evidence that perhaps some colleagues will talk more about, that those trained, perhaps particularly in pharmacy, aren't always using those skills. And there's some evidence looking at why that might be, looking at the kind of barriers to optimizing the use of non-medical prescribing, which might range from lack of resources and support networks, but also perhaps restricted opportunities and recognition from other professions. So I think in terms of the last criteria for picking this as a topic, there's something interesting about non-medical prescribing as a beam into looking at scope of practice, looking at substitution and workforce changes, and really thinking about the kind of modern 21st century health and care system, and what professionals do in the best interests of patients.